panelists here who will be giving us some interesting insights. We have Dr. Mmamoloko from Gauteng, who will just give us details about the situation in Gauteng. Dr. Nicholas Crisp, who's a DDG in the Department of Health, who will give us an update on the vaccine rollout. And also in today's panel, we have Professor Glenda Gray, who will give us some insights on new data that they've been working on J&J. We also have Professor Penny Moore, who's from the NICD and will give us more insight on vaccine findings. So we're also going to have our Q&A. We are joined by our media colleagues. Welcome. Please, we will be opening the chat right here on the Zoom platform so that you can pose your questions. And yeah, so we'll read out questions, and the Director General of Health, which is Dr. Sandile Zungu, is also here with us. We'll be just supporting in terms of the questions. We'll be fielding some of our questions that we'll be having here today. Without taking much time, I'm going to hand over to Minister to give us her remarks for this morning.
Thank you very much, Tlengiwe. Good morning to the Deputy Minister, all panel members, joined by Dr. Professor Gray and Dr. Moore, together with Dr. Mmamoloko from Gauteng, and Dr. Crisp, who will take us in terms of the work that we are doing in the vaccine rollout. Let's appreciate South Africans who continue to follow the discussions and what we are briefing the nation on every Friday. We do believe that this is more important for us to continue updating the nation on how we are managing the pandemic, but also our vaccine rollout, and thank the broadcasters who are partners in making sure that we can be able to take the message to the houses, to the families, and to our people. In the last 24 hours, we saw the rise of numbers, passing almost 20,000. We are sitting at 21,584 new cases, and also which is higher than average number of new cases per day over the 7-day preceding that we have seen. The positivity testing rate has also increased from 27 to 28.4% in the last 24 hours. This shows increasing number in many provinces across actually, but Gauteng continues to be the epicenter of the new infections, with the number of new cases having risen to 12,806 last night, which represents 60% of the total number of new infections, but also a positivity rate of 37%. We remain very worried about the increased number in hospitalization, which is putting a lot of strain in the health facilities in Gauteng. And as I said, we are joined by Dr. Mmamoloko, who will present to the public the situation in Gauteng in terms of the hospitalization and how the province is dealing with management of the pandemic and the surge. The trends are clearly showing that other provinces which are currently lagging are going to experience almost the same trend we are seeing in Gauteng, most notably in the Western Cape when we look at last night number and the Northwest, due to increasing numbers. But what worries as well is the positivity rate. If you look how Limpopo has almost 42% of positivity rate, which is leading in terms of positivity rate. We are also paying attention to what is happening in the Eastern Cape and as well as KwaZulu-Natal. So many provinces, we can say that almost at red alert for us, looking at the numbers and how the pandemic is performing. During the week, we briefed the nation, actually it's last week, nation about the emergence of a new variant in the country known as Delta. This actually is driving the third wave, and would understand that if we look in terms of the waves that we've seen, we had the Alpha that drove the first wave, we had the Beta that drove the second wave, now Delta is driving the third wave in terms of domination of the numbers that we see in terms of the variant that is present. The Delta variant, as we all will remember what has been briefed, what we took you through last week, first identified in India, I think we need to say, in October last year, but I think where many people tend to say, why didn't you close the borders of India, and are forgetting that it's actually now has been detected in 85 countries, including several countries in the continent. And it's actually rapidly becoming the dominant variant in many countries. So the question around whether you should have closed India, I think does not arise, because when you look at where this variant exists and has been dominant, you'd see that that would have been a bit of a futile exercise if you take it up. The team of scientists led by Professor Tulio Oliveira provided details about this new variant, and this highlighted that there's now good evidence that Delta is more transmissible than previously circulating viruses and other variants of concern, and that the Delta variant is quickly becoming the dominant variant in the country. You'd remember when we spoke, there was still like data that was pending in relation to Gauteng. We can confirm that data has shown that Delta variant is also dominating in Gauteng. However, it is important to just remind the public that Beta variant is still prevalent as well. It's still spreading. So you do see some of the provinces, when you look at the numbers and you look at the trends, you still see them having Beta variant as dominant. Another important characteristics of the Delta variant is that the fact that whereas with those who were previously infected by Beta variant, or during the Beta, as Beta was dominating in the second wave, were immune from reinfection by both the Alpha and Beta variant. It is not the case with the Delta variant now. This means that those who have had COVID-19 are also at risk of reinfection by the Delta variant. So it's important for all of us to understand, because this work continues to happen by our scientists as they make us understand what is driving the numbers and where we are in terms of management of the pandemic during the third wave. In terms of vaccine delivery, we indicated previously that we are expecting more vaccines to come in the country. Pfizer has delivered nearly 4.5 million doses as promised in Q2. They committed just over 15.5 million doses in Q3, of which we are expecting nearly 2.1 doses in July. Johnson & Johnson have so far delivered 500,000 early access doses used for Sisonke, 300 market doses 2 weeks ago, and 1.2 million doses landed last week. These doses all need to be used by 11 August, as we previously communicated. We are waiting for confirmation of delivery of the remaining 500,000 more doses that were part to replace the 2 million that we spoke about. In total, in the last 24 hours, we've been able to vaccinate almost 122,000 people. And also KwaZulu-Natal, just to note that KwaZulu-Natal is leading the pack, followed by Gauteng, Eastern Cape, Western Cape, and so on. But what we are interested in as well in terms of the vaccination program is to see the spread across the provinces in terms of the districts. We are encouraged that the number of vaccinations per day has surpassed 120,000, and we're expecting to surpass 150,000 per day over the next 7 days. And this, Dr. Crisp will take us in detail, and maybe just to indicate, we still, because sometimes people see the numbers daily on weekends, and they say what we are providing is not factual. We currently do not have many of our vaccine sites working over the weekends, and that's why this number represents what we do daily during the week. The vaccination of educators is progressing very well. We have so far vaccinated just over 300,000 educators. And yesterday we opened for persons which are aged 50 and above to start registering in the system. And this group will start vaccinating. As of yesterday afternoon, we had almost around 266,000 people who had registered just within less than 24 hours. And we need to indicate that we have surpassed our 3 million mark in terms of vaccination in the country. And we continue to see and push in terms of what we have promised in ramping up the vaccination process. We're also seeing parallel vaccination in terms of making sure that the frontline sectors are vaccinated. And Dr. Crisp will go into detail in terms of our vaccine program and where we are in terms of ensuring that we continue to do the work that we're expected to do. in reaching and assisting the country to reach its immunity. Today, we'll also hear from Professor Glenda Gray, who is the CEO of South African Medical Research Council. Professor Gray will present to the public the findings on J&J vaccines. We are also joined by Professor Penny Moore, who is the South African Research Chair on Virus Host Dynamics and reader, and also a member, an associate professor at the NICD and at the University of Wits. Professor Moore will speak about the question of what do laboratory studies tell us about vaccine in use in South Africa, so that all of us can be actually more informed about the vaccines that are there. We note that there's quite a lot of interest around the vaccines that we have and what we are using currently, and its efficacy based on the work that we've been communicating. I think as I conclude, and DM will do the wrapping up towards the end, but we've got both Dr. Anban and Dr. Buthelezi, who's our DG, who will assist us in responding to the question, because we'll also just highlight how we're dealing with the surge in the country, not only in Gauteng. But I think as I conclude, just to thank the healthcare workers and the doctors, the nurses, everybody else within the healthcare system for continuing to be in the forefront and helping us fight this pandemic. We do note and recognize that it has been tough, 3 waves that you have seen, helped the country to battle with. We do note and recognize that this is straining mentally, both mentally and physically. And we want to take this opportunity to appreciate you, to thank you for your work. And I hope South Africans, those who know any healthcare worker, will take a moment to send a message of support, to send a message of appreciation to all our healthcare workers as part of giving hope to the nation, but also encouraging them to continue the fight, because we do need them as frontline to help us fight this pandemic. Let me also appreciate South Africans who have heeded the call in terms of the regulations that have been imposed. Difficult as it is, you have also responded in supporting us and ensuring that you do not violate the regulations, and appeal to those also who are still thinking about violating the regulations to say the numbers continue to increase. We urge you to support us, we urge you to work with us, and we urge you to join the fight against COVID-19 and fighting the 3rd wave as it surges on. Thank you very much, Tlingi.
Thank you, Minister. I think now I will just hand over to our panelists to give the presentations.
Okay, I'm just going to share my screen. Is it sharing?
Yes, it is, Professor Gray.
Thank you. Thank you. Honorable Acting Minister of Health, Deputy Minister of Health, DG, DDG, and all colleagues, all protocol observed. Thank you very much for allowing us to present some of an update on the A26 COVID-19 vaccine, or also known as the J&J vaccine. Just to give you, sorry, my screen is not moving. Sorry, I don't know why that's happening. I'm just going to have to stop sharing. There we are. Can you see now? Sorry, it's moving. Have you been able to see?
Yes, we can see it.
Yes.
Thank you. So just to let you know that the Sasonki study completed on the 17th of May. We were able to get to 95 sites, and we also were able to touch rural and urban sites, and as well as using mobile units. We managed to vaccinate almost 480,000 healthcare workers, and this pictures on your right just show you the queues and the demand of healthcare workers to receive the single shot J&J. Just to go a little bit into some background, people are always asking, are our vaccines effective against the variants? So I'm going to start off with just the data that we have against the beta variant. The beta variant was the variant that was circulating in our country at the time where a lot of these studies were done. And you can see the Janssen that evaluated the single shot J&J. We were able to demonstrate that the vaccine was 64% effective in South Africa, and where 95% of the cases were from the beta variant. When we look at the Novavax vaccine that was also conducted at the time where the beta variant was circulating, we saw also a drop down in efficacy to 48.6%, in South Africa. And then also with AstraZeneca, there was a study being conducted which showed 10% vaccine efficacy against the beta variant. And you can see the beta variant did reduce the efficacy of all the vaccines, whether it was the J&J, the Novavax, or the AstraZeneca. And so obviously the next, so this slide just shows you that the J&J vaccine results, because the study was conducted all over the world, supports protection against emerging variants. And so if you look at this slide, it shows where the studies were conducted in the United States, in the Americas, and in South Africa. And when we look at the vaccine efficacy in America, we see that it is 86% against the D14G variant, which was circulating at that stage. When we look at the vaccine efficacy in Brazil, we see it was around 88% effective, where the P2 vaccine was a dominant, was at around 69%. And then in South Africa at that stage, where 95% of the variant circulating was the beta variant, we see that the vaccine was 82% protective in severe or critical disease. So we see that the vaccine is protective against emerging variants. So the question we have to ask is, how does the J&J vaccine compare between Delta versus beta variant of concern? So what we have seen and what results will be coming out is that the in vitro work, the J&J vaccine works better against Delta and gets better over time with both Delta and beta variants of concern. So this is very important to show, and I'll show you that data right now. So if you look at this is a study done, and it's in participants, and it follows people up over time. On your right, on your left is the people who got the placebo. So you can see there's no impact there. And on your right are two graphs. One is at day 29, so 28 days after receiving the vaccine, and the other one is at day 239, which is after receiving the vaccine. And you can see, and I've marked in red bubbles and in arrows, the beta variant and the Delta variant. So if we go to day 21, this is 28 days roughly after your first vaccine, you can see that as compared to the Washington strain or the ancestral strain, which is WA1 2020, that the A26 vaccine works best against this strain. However, if you look at day 29 for the beta variant that was circulating in our country and the Delta, you can see that there's less escape with the Delta variant as compared to the beta. But over time, both improve, and that by the time you get to day 239, you can see that the Delta, the activity against Delta is almost as good against the Washington strain. And Penny will speak more about this in the future. But what this slide shows is that the immune response matures over time, and in fact, the vaccine gets better with both the Delta and the beta virus over time. So the question I get asked all the time from healthcare workers is, do we need to boost the J&J vaccine? And from the data that I'm going to show you now, the answer is no, we don't need to boost just yet. So this slide just shows the tests that we do in individuals who are in clinical trials. And this is taken from participants who got either one shot or two shots of the J&J vaccine, and looks at various markers of the immune response. We look at antibody titers, we look at neutralizing antibody titers, we look at CD4 and CD8 T cell responses. So we look at both humoral. To get a protection against a vaccine, you need to look at both the humoral and the cellular immune responses. And we want to see good responses in both domains of the immune system. And so you can see in these participants, so the three arrows in the red show a participant that got SARS-CoV-2, a breakthrough infection, and others that got an mRNA boost. And you can see that over time, that the immune response is maintained and is durable in all domains of the immune response, both humoral and cellular. If we take out the people that got infected and if we take out the people that got an mRNA boost, you can see that the single shot J&J vaccine is comparable to the 2 doses. So this single shot works just as well over time as the 2 doses. So right up to around 8 months, we can say that we have durable immune responses as measured in people who we're following up over time. Also, what's important is not only just the immune response that I've showed you, but does this vaccine work against Delta and Beta at 8 months after following up these participants? And yeah, you can see quite unequivocally is that the single shot J&J vaccine works against the Beta and the Delta variant of concern at 8 months. And so you can see that if you compare it to the Washington strain, the ancestral strain, the WA1 2020, you can see that the Delta, which is the B16172, works just as well as compared to the ancestral strain, and has improved over time in the Beta variant of concern. So this is just to reassure the public that we don't need to boost the Johnson & Johnson vaccine just yet, but we do need to keep following up participants to see when the durability of the immune response wanes. So in conclusion, I want to say that the Ad26 J&J vaccine works well in South Africa with the difficult Beta variant that we had. All the immune responses that we see, all the data that we see indicate good, immediate, and sustained immune response against Delta. And we see surprising durability in the immune response for the single dose J&J right up to 8 months. And I want to just re-emphasize as well that the global real-world effectiveness study shows similar vaccine efficacy as the phase 3 randomized control studies. And the same is expected for Sisonke. We do expect to see real-world effectiveness of the study. So I just want to thank everybody for allowing me to show the data, and I'm very happy to take questions. I'm going to ask Penny Moore to now explain the kind of experiments we do to evaluate the immune response and the activity against the variants of concern.
Good morning, Honourable Minister and colleagues. Yes, thank you, Brenda. I'm going to take a little bit of a step back and try to explain in a little bit more detail how we do these kinds of laboratory assays and what they tell us about the vaccines that are currently being used in South Africa. But I'm going to start by reminding you, as you've already heard several times this morning, that although our initial epidemic, the second wave, was driven by Beta, which is, as Professor Gray mentioned, an extremely neutralization-resistant, very difficult variant. In recent weeks, it has been replaced by the Delta variant, and that's shown here on this graph. So essentially, each of these epi weeks shown down here at the bottom is as we proceed in time through this year. Blue here is the Beta variant. This is the variant that drove our second wave, and that proved to be so very difficult in terms of being sensitive to the vaccines that we had. But if you look at the increase in the green curve, this is the Delta variant. This is the variant that has now replaced, in many cases, the Beta variant, and this is a similar version of the data that you heard in the previous press briefing from Professor D'Oliveira. So essentially, I think the point that we need to remember here is that although there are, as you can see in this graph, other colors here, in a large measure, our epidemic now in South Africa is driven by the Delta variant. So it's really crucial that we understand how that variant reacts to the vaccines that we have in South Africa. So I thought that what I would do is to show you a little bit about how we actually do these assays so that you can understand the results that Professor Gray has presented in a little bit more detail, and then expand that to some of the other studies that are being done. To do the kinds of experiments in the lab that Professor Gray presented, essentially what we do is we take a group of people, shown here in green, who who receive the vaccine, what we do is we take some blood before they receive the vaccine so that we understand what their immune response looked like before they became vaccinated. Then they receive the vaccine, and that's this little injection that you can see here. And then at about 28 days, and it depends entirely on the type of vaccine, at about 28 days in the case of the Johnson & Johnson vaccine, we take some more blood. And what we do is we take the blood from these individuals and we ask a very simple question. We ask, how well do the antibodies that were triggered by that vaccine kill the virus? These experiments can be done in the laboratory, and they've proven to be extremely useful in understanding how well vaccines are able to deal with the various variants. We did a lot of this work looking particularly at the beta variant because of our concerns. That was the second wave variant, because of our concerns that the vaccines may not work so well. And many people across the world are now doing those same experiments to understand how well these same vaccines will deal with the Delta variant that we now have in South Africa. The reason we spend a lot of time, and you heard Professor Gray speaking a lot about neutralizing antibodies, and the reason we spend a lot of time trying to understand neutralizing antibodies is because there's increasing data from many, many groups across the world that suggests that the amount of neutralizing antibody that's present in your blood predicts how well your vaccines will protect. And that's shown here in one of several, and I'm going to show you two of these, but one of several studies that are emerging that suggest that the levels matter. So down here at the bottom is the level of neutralizing antibody, and on the vertical axis here is protective efficacy. So the higher you are here, up in the top right, the more antibody you had and the better your vaccines worked. As you move down the curve, you can see that that down here, this side, there's less antibody, and that correlates with less protective efficacy. So it looks like a very complicated graph, but the bottom line of all of this is that if you look at all the vaccines that have been tested across the world in many, many clinical trials, in many, many people, the better the antibody responses, the better the protection. And that's why we spend so much time trying to understand antibodies in the lab. This is a similar plot, and again, you can see that the diagonal moves down here from the bottom left up to the top right. And simply put, again, this is another study by another group of people looking at all the vaccine trials that have been conducted across the world, and again suggests that the better the antibodies, the better the vaccine. So that gives you some context for why Professor Gray spent so much time explaining in her presentation why the antibodies that are triggered by the Johnson & Johnson vaccine are able to recognize Delta. That is good evidence that we will be protected using the Johnson & Johnson vaccine against the Delta variant. Happily, it is not just the Johnson & Johnson vaccine where we see promising laboratory data against the Delta variant. This is data, published data from a group in the United Kingdom looking at two more vaccines, the Pfizer vaccine here on the left-hand side and the AstraZeneca vaccine on the right-hand side. It's a slightly complicated graph, so I'm going to go through it slowly. But essentially, what you need to focus on is the original variant, the beta variant that dominated our second wave, and now the Delta variant that dominates our third wave. These numbers up here give you an indication of how good the antibodies are. So for the Pfizer vaccine, against the original variant, the antibodies were really good, more than 1,000. Against beta, the antibodies dropped right down to 146, indicating that the vaccines would not work so well against the beta variant. But when we look at the Delta variant, which is now the variant that's circulating in South Africa, you can see the numbers have gone back up again. And remember, I said the higher the numbers, the higher the level of antibodies, the better the chances are that the vaccine will protect. It's the same here when you look at the AstraZeneca vaccine. Against the original variant in orange, the number of antibodies was 306. When we tested those vaccine sera against beta, remember the second wave variant, you can see that number dropped right down to 34, and this is our concern. But when we look at the Delta variant, again, that number's gone up. So the bottom line of all these slightly complicated and intimidating laboratory assays is that when we measure neutralizing antibodies in the laboratory, they correlate well with vaccine efficacy. So lab studies provide another measurement of how well vaccines will work. They're not entirely predictive. They're another measurement, and they complement clinical studies. And those two things need to come together well, and they have done in many cases. So the punchline of all of this work conducted in many, many labs across the world is that the existing laboratory data suggests that vaccines that we are using in South Africa will work better against Delta than they would have done against Beta. And there I'll stop. Thank you.
Okay, thank you so much. I think we will then take Dr. Nzagisi Maluleke from Gauteng for the next one.
Thank you. Good morning, Honorable Minister, Deputy Minister, DG, colleagues and members of the press. I'm going to be giving a brief summary of the work that has been done and is being done on the various hospital platforms across the Gauteng Department of Health. As mentioned by the Minister in her introductory remarks, we have been responding to the increased number of hospitalizations that we've been experiencing in the province following the increase of active cases in this current wave. As of the 23rd of June, the 7-day rolling average of new admissions was 631. This average number of new admissions is approaching the peak that we observed during the second wave of 649. We've been taking recommendation from the modeling team that's been led by Prof. Malado as to the number of hospital beds that we need to avail for this current wave. First, modeling predictions predicted that the Gauteng Department of Health across both private and public sector would need to avail 6,000 beds to be able to respond to the third wave. This was taking into base case scenario of active cases. Worst case, it was recommended that we would need 8,000 beds. However, in light of the news that we now have the Delta variant being dominant within our province, Prof. Malado and team had to go and recalculate these modeling predictions, and the predictions now state that we need to ensure that we have 9,500 hospital beds that are available across both public and private sector. So in response to this recommendation, we have been doing work firstly around ensuring that our health infrastructure as well as health technology is available. This is work that has been done since last year, March, during the first wave, and has been ongoing as we create permanent long-term additional capacity for the province, and also ensuring that we are able to provide infrastructure that is of quality to respond to the needs for health service delivery. We've looked from the pool of hospital beds that we have across the province, from the 18,000 odd beds that we have. And what we've been doing since March of last year is decanting wards in existing facilities to upgrade them in line with the WHO standards for COVID-19 care. We've also repurposed a number of additional beds across facilities and built a few alternative building technology facilities. And when numbers were increasing and considerations were made, field hospitals have been opened and as well as closed as the need arises. So where are we in terms of the number of hospital beds currently? For Gauteng, in the public sector, we have now repurposed 4,050 beds, and this also includes ABT beds. At the beginning of this wave, we had 2,728 beds. Additional beds that we have added to the system for particularly COVID-19 cases are 1,322. This is just some of the facilities that have been added The bronchospray facility, which is a donation from BMW, is a 150 bedded unit that is in Tshwane. Then we've got Jubilee, which is a 300 bedded ABT structure, also in Tshwane. Coupled with Jubilee, we also have Dr. George Mukari ABT in the Tshwane region. And on the West Rand, we have renovated the Anglo Gold Ashanti Hospital, which was a donation to us from the mining industry. And then we've also got Chris Hanibara ABT, which is a 400 bedded unit. The approach that we've been taking in increasing bed numbers for this current wave is a risk-adjusted approach. What that means is that as we see the need for hospital beds increases, we've been responding accordingly. One will note that there are still non-COVID services that still continue during this time. So as I've mentioned, we've increased those 1,322 beds for this wave to total 4,050 beds. We also have daily engagements with our facilities to ensure oxygen security, PPE security, and respond to any troubleshooting issues that we may have on the ground. Currently, we are ensuring that health personnel is being recruited to be able to man the beds in the ABT structures that I've just shown. And additionally, we have decommissioned some of our services to be able to repurpose and open up additional beds during this high pressure time. The bed distribution across the province for dedicated COVID beds is as illustrated on the slide, where city of Johannesburg and Tshwane have majority of the beds. And then Ekurhuleni, followed by Ekurhuleni with 950 baseline beds, and then the West Rand and Sedibeng. We have been working closely with the private sector to ensure that we are responding to the third wave. And for this current wave, the private sector has availed 5,635 beds, of which 3,866 are general ward beds and 1,749 are high care or ICU beds. Part of response has also been ensuring that we use health information and data to be able to respond and know where our challenges are so that we can increase resources in areas of challenge. We have a bed management dashboard, which is an operational tool that we're using to see which facilities have the highest number of admissions, which facilities have the highest number of PUIs, and also where the pressures are, whether they're in general ward beds or in high care beds, so that we respond accordingly. So the question always is how many hospital beds are available, and current hospitalizations across the province for COVID positive patients lies at 7,515. 5,105 of those COVID positive patients are lying within private hospital beds, and then 2,410 are within the public sector. Both private and public sector bed occupancy rate is sitting at 91%. Majority of the patients in private are within the net care hospital groups. And then as far as the patients who are in the public sector, I will illustrate by district where they are. So as mentioned, had we not increased dedicated COVID beds for this wave, we would have been sitting at a bed occupancy rate of 135%. But from responding to the recommendations from the modeling team, we now are sitting at a bed occupancy rate of 91% when we include our PUIs. We include our PUIs because we are responsive to the fact that our PUIs are also ill and also require a hospital bed. PUIs are patients who are under investigation awaiting their COVID results. In the city of Johannesburg, we've been seeing particular pressures, especially at Chris Hanibara, which has been bearing the brunt of majority of the patients in this province. They have been given additional human resources, which I will speak about later, and also have the ABT, which they are using together with staff from Charlotte, and SANDF as a step-down facility from the COVID corridor that they've created within the hospital. Ekurhuleni does not have as much pressure currently in terms of bed occupancy rate compared to the other districts, but we do continue to keep an eye on them. Majority of the patients within this particular district are at Tambo and Tembisa, and they have been also referring stable patients to Bronchosprate in Tshwane. Sidibeng had a few pressures 2-3 weeks back after outbreaks in the region. We then commissioned a team from the Gauteng Department of Health as well as the WHO to assist us in alleviating the pressures within this current district. And one can see that that team has been is tremendously assisting in ensuring that the bed occupancy rate doesn't increase above this 80% that they've been sitting at currently. Tshwane is of concern. 2-3 weeks back, they've had outbreaks in Tshwane region, health sub-district 3, and we are now seeing those patients. They currently account for over 40% of the patients that have been admitted within the Tshwane region. West Rand has been a region that we've been keeping a close eye on, as they've been having tremendous pressure for the last 2 weeks due to the influx of patients, firstly, that would have originally have gone to Charlotte, but Charlotte staff has also been deployed to Leratong to open up additional beds in order to assist them. And Leratong has also been sending some of their patients to their sister hospitals in the region, including Anglo-Gold Ashanti. One major pillar of response has been the human resource response, and we do know that human resources for health are a scarce skill, and they're often a challenge to acquire. In the Gauteng Department of Health, we've been responding through the different waves by availing budget to be able to add additional personnel and assist the facilities, especially those with high pressures. And currently, for this current wave, we've added 5,541 health personnel. The personnel has been is being recruited to be able to man additional beds in the ABTs. And of last week, we were given additional budget to be able to assist facilities that had lost some of their COVID posts to be able to respond to this current wave. So in the coming few days, they'll also be recruiting additional personnel to assist in the fight against COVID. In order to man the COVID beds, as I've said, money had to be repurposed specifically to open up additional beds. The beds that have been opened to date from this additional funding from the last 10 days are 86 at Bara, 25 at Jubilee, 10 at Anglo-Gold Ashanti, and 62 beds at the Dr. George Mukhari ABT. Bronchosprate is still continuing to recruit, and early next week, they'll be able to add more beds from the money that has been availed to them. Part of response is also ensuring that we have oxygen security as well as available PPE. We are having daily engagements with AFROX, with all the facilities in order to troubleshoot any oxygen security challenges. Of note right now is that AFROX has decommissioned some of the industrial oxygen for use within the medical sector. They also have personnel on standby for us to be able to assist with any challenges that the facilities have. And they have an early warning system for the bulk oxygen tanks, which they keep an eye on. And the minute that those levels drop to around 50%, they're already on standby to deliver additional oxygen, so we do not run out of oxygen in any of our facilities. We have had an increased need for portable oxygen cylinders, and they've also responded to this particular need by increasing oxygen cylinders that are portable. PPE is being monitored centrally. The acting CFO and her team are ensuring that PPE is not only available, but that it is also of quality. And during any challenges in our daily engagements with the facilities, they also mention whatever issues they have, and then we are able to respond accordingly. We have a list of PPE that is essential and PPE that is non-essential, and we are ensuring that the essential PPE is available in order to reduce healthcare worker infections. The other part of response is the emergency medical services. We have been experiencing increased interfacility transfers, increased calls for ambulances, as well as increased mission times, especially in our districts with increased COVID cases. And so additional resources are also being given to the emergency medical services to be able to respond to the current service delivery needs arising from COVID. And in conclusion, we would just like to urge the public to heed the call to stay at home. Prevention is better than cure. We do continue to work hard to ensure that there are adequate services in terms of hospitalization to respond to this current wave. But please, please stay at home, wear your masks, wash your hands. Thank you.
Okay, thank you so much, Dr. Maluleke, for that presentation. We'll just move on to Dr. Crisp, and so that we can take questions right after him. We expected to wrap up this media briefing at exactly 9 o'clock. We have another briefing coming through. Thank you so much, Dr. Crisp.
Okay, thanks very much. I'm also going to, good morning, everybody. I'm just going to have put my slide up as well, and I'll talk around it. Okay, thanks very much. So the question is, with all these good information and the good news that our vaccines work, the question is how far and how fast can we get the vaccine out into the community? So this first slide shows that we have in the past 24 hours been able to vaccinate 122,701 people. Those are the records that are on the electronic vaccine data system. There have been some records that have been captured on paper and will need to be back captured. So over time, these figures will change, but they all change up and not down when we are able to upload some of those that data. You can see in the graph on the left-hand side, the vaccines administered by province in the last 24 hours. And you can see on the right-hand side, the gray and the gold-colored bars where those vaccinations are taking place in the public and the private sector. And this more or less reflects the percentage of people in those provinces that are either insured and on medical aids or not insured. So we are monitoring to see that we are reaching the population we want to reach and that there's equity in the way in which the program is rolling out. I'll come back to some details about that slide in a moment, but I want to show you the other slides. This is the cumulative number of vaccinations that's been administered. You should be familiar with these slides now because they're in the public domain and on the public dashboard. It shows that we have vaccinated just over 1.1 million people so far. You can see on the left-hand side, the small graph down here shows what was happened during the Sisonke trial. And then as we switched over on the 17th of May, you see the uptake now of the vaccinations administered week by week in the period since the 17th of May, where we now have 2.67 million people who have been vaccinated with Pfizer vaccine. In the last few days, there have been just over 300,000 Johnson & Johnson vaccines administered to workers in the education sector. Which will in future slides be shown separately so that people can see which is going where. We also have started with second dose Pfizer vaccines on Monday this week, and they will closely track these initial vaccination trends from the first week. And in going into the future, we will also reflect first and second dose Pfizer vaccines so that we can see how many new people are getting some vaccine into their bodies. You can see the cumulative total now since the end of the Sisonke trial in the graphs on the right-hand side. And the Sisonke portions are shown in gray, and the green portions are shown showing what has happened in the national rollout. So you can see, obviously, the province that's got the most population, target population, is Gauteng, and they have got the largest number of total vaccinations, KwaZulu-Natal being the second biggest province. So these more or less represent the proportions of the provinces, but we're very pleased to see how well Limpopo has been doing. Although they've got a smaller population, they've managed to vaccinate a large number of the target population. So in order to be vaccinated, we need to record the person and keep the record. This is a clinical record that is kept in case of need later to investigate a particular case or to follow up. So everybody gets registered. And you'll see this number of registrations has been coming down steadily for the 60-plus population, from close to 100,000 a day to only 26,000. Small number of these are still healthcare workers trickling in for registrations, and the same for vaccinations, but they're really very small numbers. From yesterday, we opened vaccination registration for the 50-pluses, as the Minister said, and by midnight last night, 354,504 people had registered. More or less half of those are insured and half uninsured. And 7,361 people in that group actually came for vaccination and got vaccinated yesterday, even though we had not officially opened the vaccination for people of that age group. So looking at the cumulative registrations, now this is how we monitor whether we are creating sufficient demand. Now that we're not in a vaccine-constrained environment for now, as the Minister said, we have received vaccinations in the recent past. So we are now, for the next 5 weeks at least, have plenty vaccine to roll out all the programs that we can. And you can see here how the cumulative registrations had started to dwindle. This will now pick up, and we will reflect the changes with the coming on of the younger age group. So these are self-registrations plus the assisted registrations when people come to the vaccination sites and are assisted to register on site. So there have been a number of questions which I'll address separately. The first one is, how do we scale this up? Because we've seen that we are now able to do, we have been doing 110 to 120,000 vaccinations per day, which is an improvement. But if we're going to target to get to 250 and even up to 300,000 a day, we need two things to happen. One, more vaccination sites with staff and vaccines, and two, more people in the demand that are routinely coming to these sites for vaccinations. So the plan was always to increase by age, and we have now started to see a dwindling number of people in the 60-plus category, and that's why we've opened from 50 to 59. In that cohort of our country's population, there are 4.8 million people, and we expect to see at least 65% of them, which would be around 3.3 million in that group. We are already planning for the uptake of the next age cohort, which is the 40 to 49s. That cohort has 7 million people in it. And as we take on each of these groups, we just make sure that we are generating demand. The reason why we are targeting age groups is because there's plenty clinical evidence that age is a major factor, more than any other factor, in keeping people well and out of hospital with severe infections. You can still get mild infections, as the other presentations have shown, but our objective is to keep people out of hospital at least, and then to build up herd immunity. So the way we are doing it is we have the community program, which I've been talking about, which targets in the primary healthcare system in the public and the private domain. But we have industry programs that are running in large businesses like the mines, the taxi industry, and so forth, where the workplace health services are responsible for those vaccinations, and they don't take resources out of the community program. We also have the essential services sector in the public sector, which everyone's familiar with by now. Started with the healthcare workers, and will continue always with healthcare workers, but not at the tempo that we did during the Sisonke trial. There's the basic education sector has been the next one, and I think everybody by now is familiar, and we are targeting just under 500,000 people in that sector, and have already completed over 300,000 vaccinations in that group in the past week. The other sectors which have already been announced previously by the Minister, and I'll just remind you about them, is that the South African Police Service is launching their program on the 5th, and there will be further announcements about that. And then they will be closely followed by the Department of Defense with the SANDF also starting to roll out programs. Both of those programs use their own resources and will not detract from the community programs. All of those programs will be using the Johnson & Johnson vaccine because, as you have heard from the Minister in her introductory comments, these are short expiry date vaccines that expire on the 11th of August. So we want to use them as fast as we possibly can with these big controlled groups. So the way in which we want to expand these, the capacity in these is to increase the number of sites. And in some sites, it's possible to increase the capacity of the site. So at the moment, we have over 600 live primary sites. That's the point where the pharmacy license is. And from there, there are a number of up to 5 satellite sites on each primary site. And they move around a bit depending on the province and depending on the demand that is created around them. And it varies quite a lot from one part of the country to the other. But there are at least 600 primary sites, and we will be increasing them steadily now, both in the public and the private sector. The way in which that's done is not arbitrary. We have a working group that is looking at where the population of various districts are falling behind in coverage, and then they're deliberately targeting that either a private or a public or both new sites get brought into action in those sites where we are not getting to enough people. There are specific and deliberate outreaches which will continue to the 60+ population. They're quite different in rural and urban areas. And most interesting, which we've also reported before, is that the rural areas are managing to register far greater proportion of their elderly population than urban areas. And there's a lot of work for us all to do to understand why urban dwellers are not registering, especially elderly urban dwellers are not registering. We do believe that there's evidence from elsewhere in the world that when this 50+ population start to register and be vaccinated, they bring the elderly, the older elderly, let's call them, with them to vaccination sites. And we are going to be monitoring that trend to see if it is what happens in our country. We obviously have to improve the distribution both of the sites and of the vaccines. And we are trying to shorten and make the vaccine distribution to sites more agile than it has been up to now. So far, it is looking good, and we are satisfied that the vaccine in the pipeline is at least stable for 7 days, so that we never run out of vaccine in the process of getting the vaccine to people. There are a number of other initiatives which are pending. We are planning some mass vaccination sites, which obviously we won't use during a peak wave. But once the wave is over, we will hopefully be ready to have mass vaccination sites available in the metropolitan areas. There are some pilot projects going on to see how we can better reach pensioners during pension pay point time, since they're already a captive population. And if that pilot program works, then every pension payday we will roll out to other pension sites. So I just wanted to touch on one or two more things. And the first one is, we are asked constantly about walk-ins. Now, the policy has been explained, and we'll try to continue to explain it, that walk-ins are an inevitable part and an important part of the vaccination program. The point about them is not whether they should or shouldn't be allowed. The point about it is how we control and manage walk-ins. So each province, and in the districts of the different provinces, the administrations have got very specific ways that they manage walk-ins. And the idea is to have both an active walk-in and a passive walk-in management program, so that we don't get overcrowding at vaccination sites, but at the same time, we don't end up with empty vaccination sites, as we have seen now in the recent week. And we're not quite sure why that has happened, but possibly because people are afraid of crowding at vaccination sites. We're busy with some research to understand if there are other dynamics that we need to be aware of, so that we can get more people to vaccination sites. Obviously, the objective is to make sure that we don't waste a single dose, and that we are able to get sufficient people, whether by appointment or whether by walk-in, and a combination of the two, to make sure that all the capacity of all sites are used and that no doses are wasted. We will try to communicate this in greater detail and with more clarity and continue to communicate it so that everybody's comfortable about what we are intending to do. The last point I would like to address is the question of prioritization. There are a lot of questions asked and a lot of groups who feel that they should be prioritized. The point is that everybody needs to be vaccinated, and there are many, many competing demands for prioritization. And so in order to address that, the president has already made an announcement long ago, months ago, about which portions of the population would be essential and should be addressed as the first parts of the vaccination program. And those are the ones we are concentrating on. And so that is why we will continue to do the age-specific general population vaccination as our primary concern, but then make sure that our essential services are protected as soon as possible so that they are able to continue to serve us as the public. That does not mean that nobody else is important or isn't a priority, but it just means that the vaccination program is not capable of getting to everybody all at the same time. And as those further programs are brought online, we will, in the days ahead, announce what they are going to be and where they are going to be. So thank you very much. I also want to ask you all to remember to wear your mask, keep your distance, and wash your hands. Thank you.
Thank you so much, Dr. Crisp. I think we should just move on quickly to the Q&A session. We have about 15 minutes for that. The Deputy, the Director General of the Department of Health, Dr. Sandile Buteles, is also here, and he'll also be fielding some of the questions. Let me just get right to it. We have a couple of questions that have come through the chat, and some of them we'll just distribute them accordingly, and I think Minister will also provide a guide in terms of some of those questions. We have a question from Ndebu, who's asking about the effectiveness of the vaccines, which is an issue that has been addressed already. I suppose that Professor Gray and Professor Moore are going to reflect more on that, but then we don't have much time as it has been responded. We have a question from Mia Malan from Begisisa. How does the health department plan for the second Pfizer doses? Are some incoming doses kept aside to make sure there are enough vaccines for second doses, or are you just allocating new doses as they arrive? We also have a question from Tsepo Pahane, who's asking with regards to the rising COVID numbers, especially in Gauteng. He's asking whether government is considering reopening field hospitals in light of the rising hospitalizations. I think I'll take that question to Professor Maluleke. Dr. Maluleke. When would these be set up? If not, why not? And at what cost? So that they can relieve the pressures in hospitals. We have Jonisai Maromo, who's from ANA. He's asking the Honorable Minister, in terms of some of the sectors, including media, which have been lobbying to get vaccinated. He says that there hasn't been much said about the vaccination of other frontline workers like petrol attendants and cashiers. So he'd like to know what are the plans. And I think that Dr. Crisp has just outlined it briefly, but then he will take that question. And we also have a question from Brent asking, why did the Sisonke numbers go up by 5 vaccinations this week after being stagnant for so long? Question 2, why was the Sisonke trial numbers removed from the report of the 30th of June and then re-added on the 1st of July? He's talking about us having a deficit. So I think that will just clarify that, Dr. Crisp, and why the health department is not separating the first and second dose when reporting. And I think just a bit of clarity there at Dr. Crisp so that we assist the colleagues in terms of the telling of those figures. And then we also have Kate Alexandra, a question to the panelists. Some between 50 and 59 have now received their first dose of Pfizer. Some apparently have gone straight to vaccination sites. She's talking about the walk-ins that Dr. Crisp has just briefly spoken to. So what is the official view on that? That question has been answered. The next question from Sue is in regards to the efforts in vaccinating over 60 who are uninsured. And then also have a question from Binu, which reads, what was the basis of the decision at the onset that the J&J would be a single dose vaccine? And then the next question, do we have commercial labs or laboratory tests to test for neutralizing antibodies after receiving the vaccine? And I think let me just leave it there. And then maybe let's start with the Minister in terms of some of the responses. Thanks.
Let me request the panelists to come, and then we'll come later. Thank you. I thought you directed some of the panelists, maybe Dr. Crisp, starting DG, if there are responses that you'd want to come through, and the colleagues who are in the panel, just to respond, and then I'll close.
Minister, thanks. I know there's not a lot of time, so I'll just address one or two of the questions. The question about the second dose, right from the beginning, we planned that the second dose will mirror, maybe not at 100%, but probably 90%, we hope, will mirror what happened in the first weeks, and then we'll pick up so that when we are doing the estimates of the numbers of vaccinations we need to give, that is tracked. And it's the same vaccine. It's not a different vaccine. It's just a second dose of the same vaccine. So we will be reporting. There was also a question about the numbers of reporting. Why don't we report the first and second doses? We will do, and at the moment it's just not shown on the dashboard, but the dashboard will be updated. It just becomes very complicated when we are showing public and private, first and second, etc. And we're trying to get it to reflect in a way that makes sense to the public and is easily visible. The question about the Sisonke numbers, those numbers will change. So what happened is at the close of the Sisonke study, it happened on the night of the 16th of May, and on the morning of the 17th of May, the new program kicked in. There was a process, there were some outstanding doses still available in the Sisonke study which had been used. And there were also some paper records or records captured on paper during the Sisonke study that still need to be captured. And the problem was to have both systems running live concurrently is complicated, and changing the Sisonke data all the time is exactly what you are complaining about or have observed. So what we have decided to do is to wait until we have the final and conclusive tally of all the paper records and the additional vaccinations, and make sure that we then represent them as a batch and report on them as one. So the actual vaccination figure is bigger than what you see in the figures. We also know, for instance, that at least 30,000 records for the education program have been captured on paper. So you will see the figures change from time to time, and there's nothing strange about that. Thank you.
DG, or anything from your side?
Thank you very much, Minister and the panelists, Deputy Minister, and thank you for all the panelists for their presentations. I think there's quite a few questions, which most of them Nicholas Crisp did answer them through his presentation, but I say there is a pertinent question of when are the journalists going to be vaccinated? Yes, there is a program that we're working on with GCIS and also with SANEF to see how soon can we pull all the journalists. They are part of the other number of groups that we're trying to pull together for the vaccination program. So you will be advised soon once that background work has been finalized between GCIS and SANEF. And then there's a question that says, which vaccines will those over 50 receive? That currently, with the current regimen that we're using, we are still using the Pfizer vaccine. and we will announce when we are actually starting to introduce into the community program the J&J vaccine. Then the other questions, I think they are directed mainly to Professor Gray, Professor Pennymore, and I would request that Professor Gray comes in specifically on specific questions around the Sisonke trial. Thank you very much, Minister.
Dr. Malu, thanks, DG. Dr. Maluleke.
Thank you, Minister. I wanted to respond to the question concerning the field hospitals. The conversation of the field hospitals is a conversation that we've been having, may not be for this current wave, as what we've been doing is strengthening our existing facilities by increasing personnel and also using health technology that was used at NASRIC across different facilities. So we've basically reshifted those beds that were at NASRIC to across the province in response to the question on field hospitals. Thank you.
Thank you. Anyone, any comments, Dr. Gray and Professor Gray and Professor Mo?
Sure. I want to just say that the single dose J&J vaccine was designed as an emergency response. And so we're also evaluating the J&J in a 2-dose response, and those results will be available towards the end of the year. But we needed an urgent solution and an urgent and emergency response for vaccination. And so that is why the first Ensemble 1 was designed as a single shot vaccine. And as we've shown is that in the randomized control study and in vitro and in immunogenicity studies that we do have durable immune responses. We knew that we would have durable immune responses because we have data from the Zika virus, which is also an Ad26. It also shows durability. So this concurs with all the other data that we have on the Ad26 platform. So that was the reason why we went ahead with a single shot as an emergency response to an emergency situation in a pandemic. Penny, do you want to go?
Yes, thanks. So a couple of questions that I'd like to try and answer. The first is, do the vaccines work? And I think we want to reiterate that all the existing data that we have, laboratory immunogenicity data, effectiveness data, suggests that the vaccines that we have will work against the Delta variant. The second thing, I'm sorry about the dogs barking. The second thing is a question around antibody testing. This is a question about whether people who've been vaccinated can go out and test to see whether they have good antibody responses. We are not recommending that people do this for many, many reasons. Several of the commercial tests pick up antibodies to another part of the virus. So they're not informative. They don't tell you whether your body has responded to the vaccine. The second reason is that often people go to go and test for antibodies at a point at which their bodies haven't made the antibodies yet. Professor Gray showed you that antibodies take a little while to develop, and often it's misleading to go and get a test. And then the third reason is to really reiterate that while antibodies are a major part of your response to vaccination, there are lots of other aspects of your immune system, and they all kind of come together to protect you in vaccination. So there are many, many reasons why we recommend that antibody testing is not helpful at this stage, and there are no commercial tests for neutralizing antibodies, which are really the key antibodies. Neutralizing antibodies are a specific subset. And then there was a question around transmissibility after vaccination, which I think is worth addressing. So vaccines work really, really well, but no vaccine against any disease is perfect. And so some people who have been vaccinated may become infected, as you've heard today about breakthrough infections. So we strongly recommend that even people who have been vaccinated continue to wear masks and sanitize and to assume that there is a risk that they may still become infected, and if that's the case, they may still transmit the virus to other people. As I say, no vaccine is perfect, so we strongly suggest you continue to protect the people around you. Thank you.
Thank you. I'm not so sure which other questions are still pending.
Okay, we do have a question, but I think that some of the questions we'll end up having to respond to in writing, given the time factor. But maybe I can just read one. I think it relates to Gauteng, Minister. So the one question from Gauteng, let me just get to it. Okay, so the other question from Gauteng relates to the field hospitals that have been closed down. And I think the question is just to ask whether or not these, why have they been closed down in the first place, and what is their plan in that regard? But the other questions, I think Minister will then have to take offline, given the time, so that you are able to give space to the other media briefing that has to take place.
Maybe let's allow the DM to come through. I think we have been able to deal with quite a lot of issues. We'll continue to deal with the inputs as we interact with the stakeholders and media houses. But maybe on that one thing, it was explained in terms of the field hospitals that it was seen against the costs at the time. I think we dealt with it even in the last media briefing and in this week. We continue to ensure that all South Africans can be covered in terms of vaccine rollout. The 60 plus, maybe just to indicate, are not yet closed. So those of us who have family members who have 60 plus population, let's ensure that they register and they go and get their vaccine. 50 plus population has been open. There's been questions about the lower ages, the 40 plus, the 30 plus, and the comorbidities. Maybe just to explain on the comorbidities, because it's a question in the chat group. The issue, it will be difficult to determine when a person walks into a registration site and say that I'm a comorbidity, how will it be? So there are certain things that would have been announced. And as we look at practicability or the practical way of implementing, you find that the feedback is that it's not going to be easy to implement it. So that's why there will be a review. And that the belief is that when we look at what we are doing, it's very clear that we'll be able to do that in terms of the age groups that are higher. But the more important thing is for us to ramp up the vaccine rollout and reach out as many citizens as possible, including those that are at risk. So that's what I just wanted to say in closing, and thank everyone from my side, and hand over to the DM to do the closing remarks for us.
Thank you very much, Honorable Minister. Let me also pass my regards to all the panelists, DG, Dr. Crisp, Professor Gray, and all the other panelists. We are indeed, as already reported by the Minister, that we are indeed in the eye of the storm of the third wave of the COVID-19, as we can see over the last 7 days, the last 14 days. We've surpassed the levels of daily infections, which we realized during the first wave and the second wave. Just looking at the numbers just of yesterday, as alluded to by the Minister, that we have again crossed the 20,000 daily infections, this time with Gauteng almost double the second wave maximum daily infections. We want to again express our gratitude to our health workers who continue to be our frontline soldiers in saving the lives of thousands of South Africans who are falling sick as a result of this this avalanche of the third wave. We also want to thank South Africans who have come forward to lend a hand in various ways. Some of them have come out of retirement, some of our health workers. When we visit a number of health facilities, we meet some of the health workers who have come out of retirement to come and assist in providing care in this avalanche of the third wave. But we also want to thank those who have come forward, either as individuals or as organizations, in various ways in terms of donations, such as the gift of the givers. We know that they have come very handy in helping us with boreholes, providing water in a number of health facilities, also helping with the distribution of ventilators. And we urge all other NGOs and private sector and individuals to continue to find a way in which they can assist. We are indeed working with all the provinces to address the challenge of the demand for hospital beds including high care and ICU, including other consumables such as oxygen. We thank our colleagues from the Ministry of Finance, National Treasury, for having made additional resources, financial resources available, but also the Solidarity Fund. And we thank all those who have contributed to this Solidarity Fund for having made it possible for the Solidarity Fund to make additional resources which have helped to beef up these facilities, upgrading, adding more physical facilities, adding more beds, but also in terms of additional human resources, because as indicated by the report from Gauteng, you can have a number of additional beds, but if you don't have the human resources to make sure that these beds can be activated, this will not be helpful. Currently, we are paying special attention to Gauteng, as everybody can see that the tsunami of the third wave has descended quite severely in the Gauteng province. And as already reported by Dr. Mmamoloko, we're working with them to make sure that there's additional capacity. The pressure is huge. As you have heard, that we are now at a stage where there's more than 600 new admissions just on COVID per day. We almost surpassed the previous 2 waves. So, but we want to emphasize that while the pressure is now on Gauteng, we are also focusing on all the other 8 provinces, because the trend is very clear that the numbers are rising, and in no time, other provinces will also be experiencing the kind of pressure which Gauteng is experiencing. So we're working with all the other 8 provinces to prepare and make sure that as the numbers increase throughout the country, our facilities will be ready. I wish to again remind South Africans in as far as the preventative measures, as already mentioned by the Minister and Dr. Crisp, that as of yesterday...
that's the Deputy Minister of Health, Dr. Joe Pasha. They're just concluding on this media briefing. Quite important information there shared.